then this give time for everyone else. You guys already did it to get your cameras on. So here we are at week 8. We have our quote of the week. We are looking at chapter 4, health care facility structure and environment. We have Kahoot, and then we're going to wrap it all up. So, as per each week, we do have our quote of the week, which we're going to get into right now. All right. Your quote of the week. Your mind is a garden. Your thoughts are seeds. You can grow flowers or you can grow weeds. The quote relates to us as STs and future STs, right? Because it emphasizes the impact of mindset on performance. Positive thoughts, like confidence and focus, are like flowers. They enhance teamwork, they help with patient care in the operating room, and overall gives the best possible outcome. Negative thoughts, like doubts or fear, are like weeds. They can hinder your ability to perform well and affect patient safety. Just as a garden requires care, we as STs, we have to have our mindset nurtured, focusing on growth and improvement for the benefit of both personal development and patient outcomes. So remember, our mind is a garden. Our thoughts are seeds. We can grow flowers or we can grow weeds. All right, now into chapter 4. Our learning objectives. We have to look at the principles of the operating room design, which is really awesome because now we're starting to get into what we do as STs. We're going to look at some common items found in the operating room or surgical suite, like we like to say. And we're going to talk about the functions of a lot of areas in the surgical suite. But we always got standards. So make sure you guys are going back and being able to identify what is APIC versus OSHA versus EPA versus AHRQ. Okay. Keep in mind that these organizations that you see in front of you help shape how we work in the operating room and how we actually jump in there and protect our patients and ourselves. Okay. One of the biggest things that you're going to hear a lot is accreditation. Now, accreditation in healthcare refers to the process where we as professionals assess or we have our facilities assessed. Our policies are looked at, the way we treat our patients, our patient care outcomes, and it's all to meet established standards. Now, the Joint Commissions, or TJC, as you see on the screen, is the leading accrediting body for healthcare facilities. And what it does is it ensures that we provide safe and quality care to our patients. You can learn a lot more. The chapter does give you the link, and I did place it here, jointcommissions.org, if you want to know a little bit more. Now, let's get into the principles of the operating room design. The surgical department is structured and engineered to provide a safe and efficient environment for our patients. Okay. So we have infection control. We're not trying to get anybody sick. The design helps to kind of minimize the risk of infection through proper ventilation that we're going to talk about in tonight's live session, through sterile areas that we're going to talk about, and of course, hygiene protocols. With environmental safety, the layout just makes sure that it's safe. Like we're not tripping over each other. We don't want people to slip or fall. And we do want to have access to a lot of the equipment that we have in the operating room. For example, let's say who's sitting in front of me. We're going to say Crystal. So me and Crystal are getting ready to do a craniotomy. Okay. So some of the things that we're going to need, we are going to need a drill. We're going to need back table, Mayo stand. We're going to have a microscope brought in, and we may even have other individuals. We may have the brain lab in there for whatever reason. So we've got to be able to navigate the operating room without someone falling and getting hurt, which leads us to efficient use of resources. Now, the operating room is designed to optimize us as personnel, our time, our space, and materials. And that allows for just a smoother workflow and quick access to any tools, equipment, or instruments that we may need. And I want you to think about this before we get into the actual equipment. I want you to think about how the principles of preparing the operating room, looking at the design, can be adapted to balance both efficiency and patient safety, especially in a high pressure situation like, let's say, emergency surgeries. I just want you to kind of be thinking about that. Okay. So let's get into the actual equipment. So, everything that we're going to talk about, you're going to have hands on once you get into module 4, you're in the lab, and then from here on out. The first thing that you're going to see is none other than the operating room table. We have many variations of this operating room table, so keep that in mind. But this is the basic one that we can use for most any case, okay? We are going to position it for our patients before and sometimes during surgery. Now, we have our back table. This is where your initial instruments are going to go. Okay. This is how you get your initial field set up. Once you get into module 3, we're going to break that down so you can see exactly what you're going to place on this back table to help get you ready for your surgical procedures. Now, quick question. Do you think that when we have bloody sponges and different items that we just kind of toss them on the ground or just like whatever, we're just going to put them here, right? We don't do that, right? So this next item is going to be extremely important. This is our kick bucket, okay? Now, you're probably like, wait, it's a bucket on wheels. Yes, it is. It makes it easier for us to kind of manipulate it because you got to remember when you're scrubbed in, you're not going to be able to kind of be grabbing stuff to kind of get it into place. What normally would happen is it's going to be lined. It's going to have a liner, a red liner in it. And when we have very soiled sponges that we use to kind of help with hemostasis or bleeding control, we drop them. See, I'm getting used to this camera, guys. We drop them into this kick bucket where our nurse, our circulator, will pull them out and kind of count them for us. Okay. Now, don't get into too much detail here. Just know that we have our kick bucket. Okay. Now, we also have a single ring stand, and I didn't get a Mayo stand to put on here, but that's okay because I think I have one later. We have our single ring stand. This holds our sterile instruments or supplies, and what it does is it's also sterile. We put a sterile drape over it. Usually we have a sterile basin that we open up sterilely on that, and then we can place additional supplies, dressings at the end of the case, and other sterile items. Okay. And what it does is it allows it to be easily reached for us as we're at our field. And then there's some facilities that have both. You have a single ring basin and a double ring basin. Essentially does the same. This just gives you just a little bit more additional space. Now, it's important that all ancillary operating room equipment, we're going to keep all this stuff clean. We're going to make sure that we're visually inspecting it because, again, we're trying to ensure sterility and safety. Also, all of our surgical furniture and equipment, they have to have non-porous, meaning they're not going to be having holes in everything because we want to prevent the absorption of any contaminants, and we do want to make it that much easier for cleaning. So these are the basics that are in almost every single operating room. Now, I say almost because there are some special procedure rooms that you don't necessarily need all of that. Okay. So special procedure rooms are designed to kind of meet specific needs of certain medical procedures. Um, these rooms are going to be tailored to really kind of enhance patient safety. We have a colonoscopy room or a cystoscopy room. It's the first one. I should start there. Now, this one is going to be designed for procedures that involve examining the bladder and urinary tract. So the majority of the items in that room are going to be specific for GU cases. Now, that's not to say you can't do other cases in there. It just says that a lot of the equipment, a lot of the supplies that are going to be in this room are going to be specific for those procedures. So cystoscopies, bladder biopsies, and stone removals. They have certain disposables that are usually in these rooms. They have different cameras and scopes specifically for those cases. Some facilities have what's called an interventional radiology room, where there's equipment for those minimally invasive procedures like a fluoroscopy, a CT, or maybe the patient needs an ultrasound. So let's say the patient's getting a stent placement or a biopsy or an angioplasty. A lot of times they'll go to interventional radiology or those designed rooms before they come to the main operating room for certain procedures. Nuke Med is another one, houses equipment that uses small amounts of radioactive material where they're trying to diagnose or treat a lot of different conditions. Thyroid treatments are done in here, or sometimes bone scans. And then the ED. Now, I know what you're thinking. Is the ED really a part of the operating room as far as the operations? Yes and no. A lot of times there's cases that the patient is just so unstable, but surgery has to be done right then and there, that they have a space in the ED where it's sterile, where they can kind of do these procedures to get a patient stable and kind of look out. Sometimes it's trauma, sometimes it's wound suturing, or stabilization for those extremely critical patients. Maybe they were in a motor vehicle accident, a boat overturning, or something like that, where they've got to get help right then and there. Okay. Now, each of these rooms contains those specific equipment. That's the biggest thing to kind of take away from this. For example, we talked about the cystoscopy room. Well, they'll have specialized scopes. The interventional radiology, again, they're going to have imaging devices. You have nuclear medicine department, radioactive materials. So you want to make sure that you can kind of match what each of these special procedure rooms would most likely be doing. Okay. Are you guys good so far? Okay. So I have to look over here now because y'all are over here versus there. All right. Now, we look at airflow. I have seen a lot of questions on previous final exams on what I have bulleted, hint, hint, on the screen. Okay. We talk about airflow and ventilation in the operating room because it is a big thing. We're going to be talking about this even in module 3. You're going to touch on it in module 4, all the way up till your CST prep, because this is important. So NBSTSA, make sure that they have some type of question about the air exchange, HEPA filters, or laminar airflow. Okay. Now, in our environment, like restricted areas, for us, it's going to be the operating room. Not everyone gets access to our space. So it requires controlled environment to maintain sterility. We have unrestricted areas like the hallways or the waiting rooms that can actually carry in contaminants. So we're trying to make sure that whatever's outside isn't getting in. Now, air pressure is maintained at a level 10% higher than in the adjacent semi-restricted areas. We have what's called positive air pressure. It helps prevent the flow of that airborne contaminants into our space. Now, by keeping the pressure in restricted areas just a little bit higher than the adjacent areas, it will make sure that the air movement is from, and if you guys can see, it's going to be from the sterile field. So it's going away from the sterile field into the lesser sterile areas. The first time you go into an operating room and you open the door and you get that whoosh of air, that's what it is. It's almost like, get out, contaminants. You're not coming in here. Okay. So you have poor ventilation where The air particles are actually coming into the space. We don't want that. Versus good ventilation where it's coming down and away, down and away. Okay. Now, HEPA filters are installed and they are going to help remove those particles. So we call that the high efficiency particulate air, or the HEPA filters, right? We use them in the operating room because we're trying to remove that dust, bacteria, and other particles that are just lingering in the air because we don't want it to fall into the patient's wound, because that would kind of suck. Now, these filters are so important because they're trying to make sure that the air remains as free of contaminants as possible. And that's what reduces the risk of infection for our patients. We look at the laminar airflow, or the LAF. What it does is it creates a sterile environment by, again, moving the air in a smooth unidirectional flow. So it's not like going everywhere. It's just a smooth unidirectional flow. It reduces turbulence and it ensures that the contaminants are filtered out as the air moves in a predictable pattern. What that does is provide an additional layer of infection control, and that helps maintain our sterile environments in the operating room. Now, the continuous velocity ensures that the particles, they're not just going to settle down in the room, and it keeps the air sterile. Now, these systems, they have to work together, and it's to protect patients and us by making sure that the air in the room, again, is clean, preventing anything from the outside coming in that could be harmful particles. And that's what really helps maintain the sterile environment throughout our entire surgery. Temperature is another one that I have seen multiple times. And so I'll try to go slow so you guys can write it down hand in hand. We start with humidity. The operating room should maintain a relative humidity level between 20% and 60%. 20% and 60%. This is so important because we're trying to prevent growth of bacteria and mold while ensuring kind of comfort for us in the room. Humidity also prevents that static electricity, which can go in and damage our electronic equipment and our instruments. So we got humidity, check. Temperature, I have seen concepts on temperature. The ideal temperature range for the operating room is typically between 68 degrees Fahrenheit to 73 degrees Fahrenheit. So 20 degrees Celsius to 23 degrees Celsius. Make sure you know both, because I have seen it where more on the CST exam, they'll ask for Celsius versus Fahrenheit, or be able to convert it, and then you're golden. Okay. Now, this helps maintain the patient's body temperature during surgery, as well as providing us a little bit of comfort working in an environment. Those lights do get rather warm. And if you're doing ortho and you've got on a lot of extra stuff, it gets pretty hot in those rooms. So having the temperature a little bit lower does help. Okay. Now the room must be kept cool. Again, we're trying to reduce the risk of heat buildup from the lights, which are extremely hot, and our equipment. Now, I mentioned the lights. Now, if you're looking at these lights from the screen, just know that they're extremely bright. Surgical lighting is very important, right? Because if the surgeon can't see, they can't work. The lights must be bright enough to allow the team to see small, detailed structures while also minimizing heat production to avoid affecting the patient. So I want you to think of it like a directed light. The whole room's not going to feel it, but where that light is pointing at, it's where majority of the heat is. Okay. Keep in mind, we're like really in the direction of the light. So we're right there. All right. Now, modern surgical lights we have adjustable brightness and focus capabilities. So this part right here, we put on what's called a light handle, and it's sterile. The light handle goes on to the light handle, and that way the surgeon can kind of adjust it to where they need it the most. Sometimes they may ask us, sometimes if you're in a case and you're like seeing that your surgeon is struggling, you have that rapport, I've been known to kind of adjust that light for them so they can kind of see, because again, we're all in there together and we're the patient's advocate. Okay. Now, they should not cast a shadow on the surgical site because that would be problematic. We get down to gases. Okay. Oxygen, nitrous oxide, and anesthesia gases. They're controlled in the operating room. They deliver systems. They have to be carefully managed because we want to make sure that it's the correct mixture. Now, this is not something that we have to kind of figure out. A lot of times we have the gases attached, they're already attached into the rooms. And so you're literally connecting them to the wall. So it's not much that you have to really do, just make sure that you connect it correctly. Okay. Um, this also includes the vacuum system used to kind of remove waste and gases. Again, it's not going to be something that they're going to be like, Blanca, go over there and make sure that the CO2 is connected or turned on or brought in. Okay. It's not like that, but it's really important for you to know what you have in your space. Now, electricity is kind of over there by itself, and you probably didn't even notice it at first, but this I wanted to kind of point out. We talk about electrical power. It's very important for our equipment, our monitors, our surgical instruments, and lighting. It's important to have a backup power, like a generator, right? To prevent disruptions during surgery in cases of a power outage. So, a lot of operating rooms, I think mostly all of them, have this backup red that you hook up to in case there's a outage. So, like the power in the hospital is going to go down. We're in the operating room. We got a patient on the table. We are going to have emergency power. Okay. So we have these emergency power outlets. They are identified by the color tags. A lot of times we just have them red and have emergency on it. It makes it just easier. You know where it's at. And they're connected to emergency during, let's say, a power outage, like I mentioned. And the exact identification method is going to vary from hospital or surgical facility. But I wanted to grab like a basic one that are at my facilities so you can kind of see like this is what if you're looking for, look for something with a tag emergency. A lot of times there are going to be color coordinated. Okay. Now again, we have a lot of areas. Okay. Your unrestricted areas. This is another big ticket that I have seen. So we start with our unrestricted areas. Okay. These are going to be areas that there's not really a specific dress code or, a control to kind of enter. It's like when you first walk into the hospital. Okay. Not the operating room because we have special tags to get into there, but you're just walking into the hospital itself. Hallways, general waiting areas. You're going to be outside the surgical department. Okay. Unrestricted. People are walking in, walking out. But then they're going to get to what's called a transitional zone. This area is kind of like a buffer between the unrestricted and the restricted zones. This is where we like our locker rooms. Okay. When we're getting into our surgical attire, our scrubs, our mask, our shoe covers. It also separates the sterile environment from non-sterile spaces. For our personal attire, when we get into our personal access, you have your badge, you have where you have to wear appropriate gown, gloves. Your mask comes on when you open up your room and you're getting ready to prepare for your surgical case. Okay, so we're not walking in the operating room with masks on all the time. We have areas where we grab our masks. Okay, our lounge. This is going to be where we as staff, kind of like everywhere, you're taking a break, you're going to lunch. It's going to be separate from surgical areas and it may contain seating, vending machines, and other amenities for us. Also, the lounge is where we'll do like a lot of in-services where reps will come in and bring us food. We'll do potlucks and different things like that. Your surgical offices, the chapter wants you guys to know about where administration is. Okay. They are doing the paperwork, consults, or charting. Again, we have our pre-op, post-op, our scrub sinks. Now, our scrub sinks are usually located in front of each operating room. Why do you guys think that is? Why would we put a scrub sink with a window in front of our operating rooms? What do you guys think? Again, there are no wrong answers, okay?
To make sure everything goes smoothly
Yes.
and they're keeping the
And
right proper disinfectant.
we want to make sure that, yes, exactly. We don't want, when we're scrubbing our hands, our rooms are already open. So we're able to kind of look in and just make sure nothing crazy is going on. It also is where the surgeon can kind of see what's going on, like we're opening, where we're at, and it helps us to see, okay, the surgeon's coming in. I can start ready to get ready to, get my draping ready. A lot of times, depending on who I'm working with, I may have the patient draped before the surgeon comes in. But again, it's going to be the rapport you have with your surgeon. Get into surgery as soon as possible, preventing contamination. Yes, it is all of that. Okay, all of that. We also in the children's hospital, we also have cameras, which kind of helps as well to see the room's getting ready to close. We can go ahead and do turnover, especially when we're really busy. It really does help with, that. All right. Now, that's the first half. The second half of this course or class, we have to talk about the ancillary services. We have to describe the three types of ambulatory surgery facilities. And we also have to look at what's good and what's bad about both. And it really depends on the individual what you like. Okay. We look at healthcare insurance and we're going to have to look at the chain of command and then identify perioperative professionals. There's a lot that you guys can do or we can do. So, right off the bat, we have different departments. Okay. Each department has a specific role, but all work together to provide safe, effective patient care. Okay. We look at pathology. They're going to be the one that diagnosing, providing those lab tests for us. We have nuclear medicine. Remember, we sent the patient to nuke med earlier, right? They got imaging for us. So now let's say we had a biopsy needle that was placed in a nuke med. We bring them into the operating room. We kind of have an idea of where we need to go to remove that mass. See how it all kind of works together. Now, with infection control in the safety and quality section, they're trying to prevent infection. Okay. They work with biomed. They're the ones that, like, let's say an equipment isn't working properly. Biomed is the ones where we're like, here, take this, fix this. When do you think we're going to get it back? Or are we going to get it back? In that same area or down below, we look at material management down here with our supplies. We can't do surgery if, let's say, we run out of sponges. Like, what are we going to do? We don't have any sutures. So we're letting them know, hey, we need this, supplies. We're sending out different things. And we look at our operation services. These are going to support us. The blood bank, we need a transfusion. Those of you who want to go into hearts, transfusion and perfusion are really big in that service. Now, different departments, they have different roles. All are important for smooth operations, patient safety, and of course, we're trying to provide the best quality care. Now, let's think about this. If one department fails, let's say nuke med, okay, infection control, we have to think about how that may affect patient care in the operating room. So they got notice that an instrument or something in their system didn't work right. Okay. Infection started. Now they're coming to us. So we all have to work together. Okay. Failure in infection control can lead to post surgical infections. Now, issues could delay surgery or even compromise our sterile technique. We have to think about how each of these departments kind of interconnect and how, believe it or not, we're all a huge team, and we're all trying to just make sure our patients are safe. Now, if you were to ask me about ambulatory surgeries centers, I'm a little biased. I love them. Um, a lot of it being because of the autonomy that you tend to have at an ambulatory surgery, but you're moving. Okay. Keep in mind, at an ambulatory surgery, you may not have central processing or SPD, someone cleaning the instruments. You may not have someone that's going to help clean your rooms. So you're wearing a lot of hats. But for me, I enjoy it. They don't work weekends, which is not a big thing, but they don't work weekends. And the pace is really fast. Being from the Navy, and working with Navy doctors at the surgery center, there was a lot of things that I was still able to do under that scope of practice. I was still suturing, I was still drilling, I was still making ACLs. Now at the children's hospital, it's a little bit different working evenings because um, the pace isn't going to be as fast, but the cases are going to be a lot different. Now, ambulatory surgery facilities are going to be places where the patient's going to come, they're going to have surgery same day without needing an overnight stay. So we usually call them 2459s because they've got to be out 24 hours and 59 minutes. Okay. They are not going to be there for, or is it 2359? 2359, because they're not going to be there full 24 hours. Okay. Now there are different types. You see freestanding. These are going to be independent buildings specifically designed for outpatient surgeries. They are not connected to a hospital. I repeat, they are not connected to a hospital. We have integrated hospital and outpatient services. These are outpatient surgery centers located within a hospital, but they're set up to handle the same day surgeries. So let's say you have Sharp, and then Sharp has an outlet, a satellite hospital or a satellite surgery center, still kind of Sharp, but it's only going to do those 2359 cases. You have self-contained hospital outpatient facilities. They're separate, they're specialized areas within a hospital. So these are in the hospital where outpatient surgeries are performed with all the necessary services for that procedure. And then the bottom one that you see on the screen, okay, are office-based outpatient surgeries. Some surgeries can be performed in physician offices. A lot of times eye cases are in these particular outpatient surgeries. Not all, but there are some. Now, all of these facilities allow for efficient surgeries while kind of like keeping the costs down with the patients returning home the same day. Again, 23 hours and 59 minutes. Now, as ambulatory surgeries continue to expand, we think of a potential ethical, safety, and economic kind of like trade off between prioritizing efficiency and cost savings while ensuring comprehensive patient care. Now, keep in mind, these ambulatory surgery centers, they help keep costs and they have benefits, but they also raise concerns about patient safety sometimes, continuity of care sometimes. These facilities, again, they reduce hospital overcrowding. They lower expenses for both the patient, the insurers, but they may not always be equipped to handle complications that unfortunately can arise post surgery. This could place a greater burden on the emergency rooms if patients experience, let's say, an unexpected issue after they were discharged. Okay. So that brings us into real disadvantages of ambulatory surgery. Now, we look at limited physical space or even staff. Some facilities may not have enough space or staff to kind of handle a lot of complex cases. My surgery center, we did do total knees and total hips, but that was really the max. Like we weren't doing open heart surgeries or craniotomies. Granted, we did do neuro, but we were doing more L5 discectomies where we're just removing disc or putting implantations, okay, implants. There's expanded responsibilities. Like I mentioned, we may be assigned to tasks that at a hospital or a larger facility, you're not normally going to do. You're not usually helping turnover at a bigger hospital. You're not usually turning over your own instruments at a bigger hospital. You're not even usually pulling your own cases, unless you work evenings, at a bigger hospital. Okay. There is increased medical legal responsibilities as well. Now, patients are discharged the same day. There are going to be more risks and responsibilities for the surgical team. We may be asked to kind of sit with the patient in recovery for a little bit while the nurse does something. Okay. Um, there's not going to be a centralized service. What that means is these facilities may not have full range of support services like nuke med or interventional radiology, or even lab. A lot of times we send our labs off somewhere else. Okay. And then there's no skilled care after discharge because, again, they are same day. So they're usually being discharged to home or family members. There's not going to be immediate skilled care available once the patient leaves, which can be problematic if complications do arise. Okay, so that was the negative. We get it. But there are also advantages. Many patients prefer convenience, faster recovery times. That's going to be associated with outpatient surgery. Ambulatory surgery is often less expensive than patients having to go in to the hospital due to just a shorter hospital stay and fewer resources that actually need to be needed. These facilities can often accommodate more flexible scheduling, allowing for quicker procedure dates, which is really big. We also look at control over surgical environments and supplies. These facilities can maintain strict control. Like we know what supplies that we have, they're ours. And if we have to go to a hospital where we get a loaner, we're signing it out and we know what we're getting back. Okay. And then we look at efficiency. With focused specialized operations, these facilities often offer a faster, more streamlined process from check in to recovery. Now, we talked about money because unfortunately we have to. There are financing. We have public funding from federal or state programs. We look at Medicaid and Medicare. The chapter lets us know that Medicare is a government program that provides health coverage to eligible low income individuals and families, where Medicare is a federal program offering health care primarily for individuals age 65 and older and certain younger individuals with disabilities. There's the private insurers, health plans that provide or are provided by private companies or employers to just cover medical expenses. And you see a couple of the examples up there. Make sure you know the difference between a PPO, which is a type of insurance plan that offers flexibility, versus an HMO that is a health insurance plan that usually requires members to kind of choose a primary care physician and get referrals. Also, make sure you understand the payment systems. Okay, your DRG. These are systems for classifying hospital cases into groups to determine the payment for inpatient services under Medicare. Your ICD, these are going to be the international classifications of diseases. This is a globally used system for kind of coding diagnosis, enabling standardized reporting, and just really kind of tracking diseases. And the CPT codes, current procedural terminology, system of codes used to describe medical, surgical, and diagnostic services, allowing healthcare providers kind of really to talk to each other and bill for services. Now, healthcare financing in the United States relies on a mix of government assistance, private insurance, and employer based coverage. Payment systems are going to be structured using those standard codes like ICD and CPT to ensure proper reimbursement for services provided. Okay. Are they good to start with? In what aspect do you mean?
Like the ambulatory facility.
Oh, okay. Great question. One, it depends on you as an individual. I'm the type that likes the challenge of kind of like challenging myself. I like the challenge of challenging myself. I feel like it's a double negative. Um, and at a surgery center, you are expected to kind of know a little bit more because unfortunately or fortunately, they look at every case. It's time, okay? Because you're trying to move. So let's say you are at an ambulatory surgery center and you are scheduled for like just knee scopes. So you're going to be really proficient in what that surgery center does. That's the other good and bad. A lot of surgery centers, like the one I like or the one I was at, we did ortho, neuro, a little bit of general, and that's what we did. So ACLs, we were doing total knees, total joints, shoulders, hips, those cases. So you become really, really proficient and you're like moving, your surgeon, the team. It's it's a little bit closer. Now, if you like that, that's like the way to go. But keep in mind, they do expect a little bit more. Hospitals tend to be more teachable because you have your residents, you have your nurses, and it's a good way to kind of get in there and get comfortable. Once you get to your clinical sites and kind of see, like, let's say you start off at a hospital and then you switch to a surgery center, and then you're like, this is like my home. Then when you start applying, that will be the place, and vice versa. When you guys get to clinicals, one of the things I always say, it's like, that is your first on the job interview, believe it or not, because they're looking at you just like you're looking at them. And the fit has to be for both. So when you ask, is it a great start? It's going to depend on that feel when you go in, and you're going to know, like, you're going to know, yeah, this is it. Or let me keep looking. But great question. I hope I answered it. Okay. Now our positions. So we start off with our CEOs. Okay. They're the top. They're responsible for overall management, strategic direction. Where's the healthcare facility going? Okay. They're going to oversee operational, financial, administrative functions within the institution. We have our vice president. They're like the backup, right? They typically oversee specific departments, services within the healthcare organization, finance. They're really looking in and honing in to operations or clinical services. Okay. There's also the director of perioperative services. This is going to be the one that we see. Okay. They're the individuals that are looking at what's going on perioperatively before surgery. They're looking at us, our department, our staff. They ensure that there is efficient operations on the operating room or in the operating room. And that includes looking at schedules, managing resources, and maintaining quality patient care standards. We have our care manager, we have our operating room manager, we have even a post anesthesia care manager. Now, all of these roles contribute to the effective management of what we do in the operating room, from the CEO setting the strategic vision of the operating room to us that play a role just maintaining high standards of patient care, safety, and efficiency in our surgical environment. Now, with that, we still need to know our chain of command. Okay, we need to know the vertical alignment versus the horizontal alignment. The chain of command just simply refers to the hierarchical structure within all organizations that defines the flow of authority, communication, and decision making. It ensures that all members know our roles. Okay, so we look at vertical alignment. Okay, you see your surgeon, your anesthesiologist, us as the certified surgical tech, we have our circulating nurse, and then we have techs, other techs. Okay, this represents just the hierarchy of authority, with each level of the organization reporting to a higher level. At the top, we see, and for us, because I wanted it to be specific for us, we have our surgeon. Okay, which lets you know, if you see a question, who is ultimately responsible for everything that happens in the operating room to the operating room patient? The surgeon. Okay. Now, that concept is going to be asked a lot of different ways, but just know the surgeon is ultimately responsible. We all play a part, but it's the surgeon that is ultimately responsible. Now, for horizontal alignment, a little bit different. This actually refers to the roles or departments that work at the same level within the organization, but they may have different areas of responsibility. These roles are going to be working alongside just to ensure that all parts of the organization function smoothly. That is right. We're here. Thank you, Miss Quincy. Perfect. Thank you, Mark, surgeon. That's right. We're here to make sure he or she knows what they're doing. We are the team. A lot of times you're going to realize that you may know the steps 4 or 5 times ahead of, let's say, a resident or even a fellow. They're surgeons, but you're the subject matter expert. You'll be surprised how many times I've had a surgeon say, make sure you listen to Teresa. She's going to get you in. And I'm like, yeah. But of course, we still stay humbled because, there's still that vertical alignment. But once you get that rapport with the surgeon, it's really big because then you know how the surgeon gets into the different body, different extremities. You know what instruments, you know when they want the instruments, you know how they want their needles. You're guiding residents, students, other surgeons on how the surgeon that you've built that rapport with works, which lets you know, who are we? Who is in the operating room? Well, we have our surgeon. We have sometimes an assistant surgeon, anesthesia care provider. There's going to be a perioperative registered nurse, our circulator. We have PAs. A lot of times they may be scrubbed in at the surgery center. You do see a lot more surgical PAs. Our heart team has 2 surgical PAs, but they're the only service that really has them. We have our educator. They're the ones coming in, making sure that we all are up to date on all of our training. Kind of like I'm texting those or emailing those that are still doing OSHA and HIPAA. It's pretty much the educator. They're out there making sure that is. We have our surgical orderlies or our aides. They're the ones that are really helping us turn over rooms. They're getting equipment for us, unless you're at a surgery center. Same thing with your central sterile processing tech at a surgery center. You are that person. At a bigger facility, there's an entire department. That's what they do. There's the patient care tech, as well as respiratory therapy, x-ray, orthotechs. Now, not surgical orthotechs, but orthotechs that help with, they'll come in and help do casts and different things. Now, the biggest thing to take away is that all of us as professionals, we are a team of individuals with specialized roles that really contribute to the ultimate patient safety. Now, for us, it's really important to understand how our role fits in with the team and how each member's responsibility comes in and contributes to a successful surgical outcome. We have a little group activity that we're going to talk about. Okay, it's 7:30 at Blue Ridge Ambulatory Surgery Center. A patient is scheduled for a laparoscopic cholecystectomy. Laparoscopic cholecystectomy, meaning that we're going to take cameras, we're going to go into the abdomen, we're going to fill the abdomen with CO2 so that we have space between so we can actually see the organs, and we're going to take out the gallbladder. Laparoscopic, meaning camera, we're looking with the camera. Cholecystectomy, removing the gallbladder. Okay. Now, it's scheduled at 8. We just started beginning to set up. We're going to walk through who does what and why it matters. Okay. So we have our scrub, our circulator, we have central sterile supply, insurance and billing, and everyone else. Okay. Now, let's think fast. Okay. Type in the chat. Scrub tech, what's the first thing you check in the operating room? Also, sometimes we're the first individuals in the room if anesthesia hasn't come in yet. So what do you think we're going to check? See if it's clean. Yes, that's correct. Anything else we're checking? We haven't brought our stuff in yet. Yes, equipment, bed is done. Sometimes we have to get If you're at a surgery center, you got to make the bed. If you're not, you're making sure that the everyone else is coming in. Case card is in the room. That is correct. Because if we don't have a case card, that case is not going to start at 8 a.m. The instruments, you have the instruments you need, set up sterile instruments. Yes. Okay. Cleanliness, equipment, carts. Here's number two. What is our circulator going to do? The patient hasn't arrived yet. What are the priorities right now? What do you guys think? Patient's not here. Coordination, that's big. Um, do you think, yes or no, the circulator is responsible for making sure how traffic goes? Let's say we're doing a cranie. So we're going to bring in the microscope, which is really big, and we may have a drill. So we may have extra equipment. They're getting the drugs ready. Yes, they're making sure that those drugs are ready. They're making sure that we have the patient that's correct. So they're checking the patient cart, equipment, and room traffic. All right. I'm seeing the same names. Come on, you guys. Don't be afraid. Okay. This is all learning. Now, we're going to go to Central Sterile Supply. The tray for the case isn't in the operating room yet. What are we going to do? What are we going to do? We're looking at preparation and readiness. Check with SPD. Yes, we have to check the status. Where's this instrument? We need it. This case is supposed to start at 8 o'clock. Okay. And then we contact our, not necessarily our supervisor, usually telling our surgeon or our us and the nurse kind of working together. And then we're like letting the surgeon know, hey, we're still waiting for this, just so you know. Okay. Now, this one may be a little bit different. Okay. Because this is not something we constantly think about, but it's good to know. The patient's insurance info changed that morning. What must happen before we can even proceed? What do you guys think? Again, this isn't something that we're normally in, but let's say we are that insurance rep. We've got to get it approved. We got to get the information. So we're confirming eligibility. We're updating the records. We're verifying the insurance again. Yes. Seeing if there's even anything with our network, verification, verifying. Yes. Now, this is for all of us. Okay. This is the ambulatory setting. Okay. What's one challenge or benefit? And this is what you just think, one challenge or benefit of doing this procedure here, the laparoscopic cholecystectomy, that you can do at an ambulatory surgery center, just so you know, um, instead of a full hospital. What do you think? If not, cancelectomy. I like that one. And this is your own opinion. Why do you think there's a benefit? Or maybe you think there's not. What do you think? Do you think there's a benefit? Let's see. This was unexpected. And you're like, I have a choice between a hospital and surgery center. Both doctors are great. However, at the hospital, this could keep me down for, let's say, a week and a half, 2 weeks, versus surgery center. I'm in and out. ICU if there's an emergency, that's a big one. That is something to really consider. Specialization, yes, this surgery center, this is what they do. They do lap choles, lap appies all day long. Um, yes, you don't have to wait. Familiarity with the procedure, things may run more smoothly. Faster discharge, lower cost versus limited emergency support, and a tighter turnaround. Now, what's one new thing you guys understand about the team's role now that we've had this particular live session that maybe you didn't know, or maybe you did know? You guys can drop those in. And while you're doing that, what questions do you have for me? And we, of course, are short on time, but that's okay because I am okay with that. With that being said, let me see if there are any questions. Okay. The Kahoot, again, challenge yourselves. It's not a requirement, but there are 15 questions. There are true and false, and I have it set up so that you can kind of challenge yourself, meaning the true and false, there's 5 seconds, the multiple choice, there are 10 seconds. Okay. So if you have the opportunity, go ahead and knock it out. Again, this is just for you. Put it in your toolbox and help use it to help kind of gear you up for the final. I am currently going over the final, kind of looking at the questions, so that I can kind of make sure that our guide is really focused on making sure that you guys kind of hone in onto where to look at, and not just memorize, because it's not about that. As you guys can see, the stuff that you're going to have to anticipate. So I'm going to be building that up. My goal is to get the final review to you guys. I know it's week 8, but it's going to come fast. So I'm really trying to get that ready for you guys to have it the beginning of week 10. That's my goal. Okay. Ambulatory centers didn't know that. Yes, I personally love ambulatory centers. That's just me. I like that fast pace, but then I work evenings where again, it's fast paced. You don't know it's fast or slow. That's the only thing with working at a hospital and it's evenings. It's either you're going, or you're like, what are we doing? And of course, day shift, it's scheduled, the whole team is there. You have everyone if there's something to arise. So it's really what works best for you, your family, and what you're comfortable with. Okay. As we get closer and closer, this is how we're going to be kind of breaking these subjects down because pretty soon you're going to be in the lab. Okay. For those of you that are watching this archive, how might the design of an operating room influence both patient outcomes and efficiency of the surgical team during a crisis or high pressure situation? And in what ways can a surgical tech ensure the evidence based practices are consistently followed in a surgical setting? And why is that important to question outdated practices? I do want to give you guys a shout out and give you your flowers. I believe that it's important to give flowers when I notice you guys are doing phenomenal in both courses. I am so proud of you guys. We're almost there. So keep up this momentum. You have questions, go ahead and ask, okay? Because that's what I'm here to do. I've worked in one for 10 years. It's exactly, yeah, everyone is hands on deck. I particularly love them. And again, you will know your fit. But what I want you guys to think about when you guys do get into the clinicals, this is your this is your interview. But it's not just them interviewing you. You're also interviewing them. Okay. You want to know that we fit. Um, don't be shocked. I'm proud of you guys. You guys are putting in the work. Keep it up. I don't want to keep you guys any longer. The quote of the week: your mind is a garden. Your thoughts are seeds. You can grow flowers or you can go weeds. We covered a lot of what we're going to be doing. I say we in the operating room. We looked at items that you're going to be dealing with day in and day out. We talked about surgery centers. We looked at payment methods. We looked at the chain of command, and we even identified who is in there with us. Now, if there are no further questions, I do wish you guys a wonderful evening, and I look forward to everyone who can attend tomorrow's live session. Good night, everybody. Oh, do you guys like the camera? You guys can type it in. I'll talk to you guys later. Have a good night.
The little person at the screen is kind of distracting, but it's okay.
I can switch back. That's why I'm asking. Thank you for your honesty. Good night.